For the shoulder, what we're going to look at are AP, the axillary or the inferior superior axial. We're going to look at the gray sheet. We're going to look at the outlet method, and we're going to look at the AP and AP axial clavicle. We can also shoot that PA and PA axial, AC joint, AP scapula, and the Y view. So we're going to dial in the Y view a little bit more than what we did on humerus, and take a look at accurate positioning, inaccurate positioning, and how to evaluate for the most common fractures, positioning for fractures, and also positioning and evaluation of dislocation. So again, our rule of thumb, 10 centimeters or above would be shoulder size or above on average size adult. So we truly need to use a grid now. Patient position, again, if the patient truly has a shoulder injury, there's some positional pain there. So changing from a recumbent to an upright position to a recumbent position can be pretty painful. So what I would recommend that you do is, if the patient comes to you in an upright position, even if they're on a stretcher, that maybe you shoot tabletop on the stretcher. If the patient's in a wheelchair and they can stand, then maybe have them stand upright at the bucky. But if they're recumbent on a table, the only way that you can comfortably get them into an upright position is to, if again they're on a gurney, not on a table but on a gurney, is to raise the head of the gurney up with the patient, total support all the way across the patient's back in order to get them into upright position. Evaluate your patient. Also kyphotic patients sometimes are easier to do upright if the patient can stand or sit in a wheelchair. And the reason for that is that because with them laying on the table, it's kind of like getting a good AP of the chest. You're going to have to do some angulation in order to get the anatomy, this central ray perpendicular to the anatomy. And it's harder for the patient who is truly kyphotic to lay on that hard x-ray table. So evaluate your patient. If your patient is holding their arm, kind of like what I was talking about before for a broken elbow, then there's a chance that they've got a shoulder fracture. But if they present to you and there's an obvious deformity where the shoulder just looks like it's hanging low, there's a pretty good chance that you've got dislocation going on there. So we're going to talk about projections for each one of those and positioning for each, especially whenever we get into the Y view and the scapula and transthoracic, which we were already talked about, so we're not going to rehash that. For the AP of the humerus, we're going to put our central ray 1 inch inferior to the coracoid process. We'll turn the camera on again. Again, remember, we've been in isolation. And I've been in isolation for 2 weeks before that because of COVID. This is my back room. We're beekeepers, so we've got that stuff, emergency water over there. So the coracoid process, how you find the coracoid process is that soft tissue indentation just on the medial side of the shoulder and just distal to the shoulder itself. So you follow your shoulder down, and when your finger sinks in, that's where your coracoid process is. And the coracoid is just attachment for your pectoralis and your deltoid muscles. So it's that soft tissue indentation that you can find on the patient. I don't recommend that you really go poking real hard, but just for reference, that's about where it is. So if you have a kyphotic patient, even if the patient's upright, you may have to utilize a cephalic angulation. So in this case, really the benefit to shooting upright is more patient comfort than what it is positioning and ease of positioning. So external rotation, if at all possible, if you don't suspect the patient has a fracture, then you're going to externally rotate just like you did on the humerus. So again, we're not really going to beat that to death. We're going to see the greater tubercle on the outside. Remember, you're just following where your thumb is pointing. And on the evaluation, what we want to see is a collimated field that's 10 by 12, but the 12 is crosswise. So it's a shorter and broader collimated field. So we're going to be looking at all the way medially to the sternoclavicular joint. And remember, you can't really see the sternoclavicular joint, so where the clavicle ends is basically your sternoclavicular joint. So if you're seeing the end of the clavicle, that's good enough. You're going to see your glenoid fossa, but it's not going to be opened up. Your coracoid process should be in the center of the field, and it should just appear to be kind of a round density. And then you're going to have ribs superimposed on your scapula. So it should look like this. Your coracoid in this view is a little bit high. So your central ray should be about 1 inch distal to that. So the positioning looks pretty good. Notice you don't see the bottom of the scapula, and you don't really see the sternoclavicular joint on this particular x-ray. You might get to know your radiologist and determine whether or not that's an issue. You know, if patient's pain is out laterally, then that's probably not going to be an issue for most of your radiologists. But if your patient's pain is not identifiable, then he's probably going to want to see all the way around. So your glenoid cavity is here. Notice you got some superimposition of the humeral head over the glenoid cavity. Coracoid processes, that's roughly rounded appearance. Greater tubercle is out here. That would be your AC joint. And aside from the sternoclavicular joint not being represented, I'd say that's textbook positioning and appearance of a AP of the shoulder. So what we're going to want to see is the scapular body obliqued but not foreshortened. If you have a kyphotic patient, it's going to be foreshortened. And what you're going to see is the posterior portion of the scapula projected above the clavicle, so the superior scapular angle is going to be up here if your patient is leaning forward or if their natural body build is kind of kyphotic. Your glenohumeral joint is going to be closed. Again, that is going to be this right here. It's going to be closed because you're going to have some superimposition over it. Your glenoid fossa is obliqued, so the posterior portion of your glenoid fossa is more lateral than the anterior portion. If you have internal rotation, again, you're providing your patient doesn't have a suspected fracture or dislocation, you can internally rotate. Internal rotation would be to have the patient put their hand on their hip, and what that's going to do is it's going to give us our lesser tubercle, which is really kind of hidden back in here, but on internal rotation, what that's going to do is it's going to take that and it's going to project it out here. So external rotation, we got greater tubercle out here. Internal rotation, we got lesser tubercle in there. Some hospitals also include a neutral rotation, and I'll be honest with you, I don't know why. I don't know what this shows that the external and internal rotation won't show. But if you're looking at an image and you can see neither the greater tubercle laterally nor the lesser tubercle medially, then what you're looking at really is a neutral rotation. This is pretty much just a review of all that. AP is external rotation, neutral rotation just has the hand on the thigh, and lateral rotation is basically with the it would really be lateral. Medial rotation would be with the arm internally rotated so that the lesser tubercle is projected medially. So the thumb points to the anatomy that's demonstrated external rotation. Your hand is supinated, your thumb is pointed outward, so you're seeing the greater tubercle on the outside. On the internal rotation, then it's going to be internally rotated so that your thumb is pointed inward, and that's going to show you the lesser tubercle on the medial side. And the reason I went with this lateral rotation is because in the textbook there seems to be a little bit of a confusion, or the wording seems a little bit confusing. Internal rotation is where we see the lesser tubercle medially. The inferior-superior axial, or the axillary, has the arm abducted 90 degrees, if at all possible, and then the central ray should be angled 30 to 45 degrees medially. If the patient can't abduct their humerus to 90 degrees, then you're going to angle less. If they can come all the way out to 90 degrees, then your angulation is going to be a little bit more. Most of the time, I'm not going to shoot with a 45-degree medial rotation because with that much angulation on most of our patients in this region, you're going to project the head of the humerus off of the image receptor. It's important to have the patient turn their head away from the side of interest. So if you're examining the right shoulder, have the patient look towards the left-hand side. That takes the eyes and, to a lesser degree, the thyroid, and it rotates those structures away from the central ray. But also have the patient flex their neck, that is to tuck their chin towards that side as well. And what that does is it buys you a little bit of room so that you can move your image receptor closer into the neck, and you're less likely to project the humeral head off the image receptor. So in evaluation, what we're going to look at is superior and inferior borders of the glenoid fossa, make sure that those are superimposed. And we're going to look at the coracoid base and where it appears to be taken off from the rest of the anatomy. So the glenoid fossa is here. That's glenohumeral joint space, so the glenoid fossa is here. So remember how you're shooting. So this is coming up from underneath the patient. So this is the anterior and the posterior portion of the glenoid fossa should be superimposed. Now, if you follow that out, it should look like the coracoid process, which this right here is coracoid process, and it should look like these two are coming straight off of each other, when in fact they're not. They see the way they appear to be touching, but there's significant distance in between the two. So what happens is if you are over angled, what's going to show is that the glenoid fossa and the glenohumeral joint is going to be projected more towards the coracoid process. And if you've got an underangulation, what you're going to see is a gap in between the glenoid fossa and the coracoid process. So this is pretty much textbook positioning. What you're going to do is abduct the patient's humerus 90 degrees. You can have them hold the image receptor if they're capable. Abduct the humerus 90 degrees, and then you supinate the hand, which is just a natural position for the patient's hand to be in. So a Gracie method is an AP oblique position of the patient's body, and some people will call it true AP, and it's not really a true AP because the anatomy is an angulation. So to give us the Gracie method, we have to angle the patient's body. But what we're trying to see in the Gracie method is an open glenohumeral joint space. So what you're trying to see is, and what you're trying to avoid, is superimposition between the humerus and the glenoid fossa. So what we're trying to see is through that joint space right there. So since the anterior surface is more medial and the posterior surface is more lateral, then what we're going to have to do is rotate the patient towards the side of interest. So we're going to rotate the patient roughly 45 degrees towards the anatomy, and really the only thing that we're interested in seeing, we've got our central ray opened up all the way to the opposite sternoclavicular joint, and really what we're hoping to see here is an open joint space between the glenoid cavity and the humerus, so that those two should be opened up. What we should see is the acromion and the coracoid process superimposed. We should see, or if they're not superimposed, they should be drawn closer together, I guess is a better way to say that. So the acromion and the coracoid process, the distance between the two should be reduced. Open glenohumeral joint space, the tip of the coracoid process in the joint space. The clavicle is going to be greatly distorted. If in cases of over-rotation or under-rotation, we're going to see closed joint space in both of those cases, but what we're going to see is more of the coracoid process in the joint space with over-rotation, and with under-rotation, it's going to draw the coracoid away from the joint space. So coracoid process is here, the AC joint is here, so we've got coracoid process in the joint space, and we see an open glenoid cavity. So the glenohumeral joint space is good and open. If we're over-rotated, then we're going to see a closed joint space, and we're going to have a lot of coracoid process. It's all the way off, almost out of the joint space and onto the humeral head. So with under rotation, we've got the coracoid process just barely in the joint space. We still have a closed glenohumeral joint space, and that would be under rotation. So the Y view is good for showing fractures and dislocation of the proximal humerus. So fractures of proximal humerus and dislocation of the shoulder. In cases where we expect that we have a fracture or dislocation, we're not going to move the humerus out of the way. If, on the other hand, we're interested in seeing whether or not we've got a broken scapula, which is just a horrible, painful fracture, then we're going to have to get the humerus out of the way in some way or another. So if we're looking at fracture dislocation of the humerus, leave the humerus where it is. If we're looking for a fracture dislocation, or not dislocation, but fracture of the scapula, then you're going to have to move the humerus out of the way. So body position is going to be a 45 to 60 degree oblique. Obliquity sometimes depends on abduction of the humerus and where the humerus is. Sometimes it depends on the patient's body build and if they are a kyphotic patient. The Merrills in the critique book have positioning tips and hints on how to get the scapula into truly a lateral position. So the Merrill says that you should palpate the medial and lateral borders, and that obviously if the patient has a broken scapula, it's going to be very painful. But to palpate those two borders and then rotate the patient until your fingers, the two fingers that you're using to palpate both of those edges, are perpendicular to the image receptor. The critique book says to find the medial border and put it in between the coracoid and the acromion process. So it's telling you to palpate those two processes. A separated shoulder sometimes accompanies other types of shoulder injuries. And with a shoulder injury, what you may have is some sort of separation of the AC joint. So again, that may still be very painful. So what I recommend that you do is lightly place your hand on the patient's back, on their scapula. Now you got to remember what the scapular anatomy looks like on the posterior side. You've got that posterior spine, and then you've got underneath that posterior spine, it kind of sinks in somewhat. So I recommend that you take your hand and you put it over what you would feel as being the patient's scapula. And then keeping in mind that what you're feeling is soft tissue there. So put your hand perpendicular to the image receptor. With your hand perpendicular to the image receptor, then your scapula is going to be obliqued about 5 degrees. So it's going to be pretty insignificant, but it's still going to be obliqued a little bit. So what I recommend that you do is put your hand perpendicular to the image receptor and then rotate the patient. If you're shooting PA, rotate the patient towards prone about 5 degrees. If you're shooting AP, you would rotate the patient about 5 degrees towards supine. So it looks like this. You take your hand and you put it on the image receptor, on the patient's anatomy, and put your hand perpendicular to the image receptor, and then just rotate them just a little bit. It's not significant. It's not a lot of rotation at all. So it should look like that. So what we should see on the Y view is you should see A couple of things. One is the scapula, with the exception of the coracoid process, should not be on the ribs. So remember, you've got two different borders to the scapula. You got the vertebral border, which is really a fine line. It's a very thin bone. And then you've got the axillary border, which is big, fat, and puffy. So where you're looking at your rotation, if you get the patient too close to lateral, what you're going to see is that puffy border over the ribs. And also you're going to see the shoulder, or the humerus, projected more towards the ribs. So on a good wide view, what you should see is the acromion, you should see the coracoid process, and then you should see the superimposed lateral and medial borders. That is, your axillary being your lateral and your medial being your vertebral border superimposed. So you should just see one density going up and down this way, these two forming the upper portion of the Y. And then your humeral head should be over your glenoid cavity. If you've got any portion of that over the ribs, you got some rotational issues. So think about your normal AP of the shoulder. The axillary border is out laterally, and the vertebral border is under the ribs. So if the patient's to AP or to PA, then what you're going to have is the vertebral border over the ribs. So that pencil fine line border is going to be over the ribs. If the patient gets up too close to lateral, then what you're going to have is the puffy border over the ribs. Now, if the patient has a fracture of the humerus, if these two were superimposed in this image, you're going to see both sides of the humerus away from, medial and lateral to the body of the scapula. So you're going to be able to see the fracture. So even though the humerus and the scapula should be superimposed, kind of like what you're seeing right here, they're superimposed, you should still be able to see a fracture line. The diagnosis of a dislocation is that maybe your scapula is in perfect position, but your humeral head, which is right here, is going to be out in somewhere. Statistically speaking, 95% of your shoulder dislocations are going to be anterior dislocation. So this thing pops out and it moves anteriorly over the ribs, and it's going to be a little bit inferior. So what you're going to see is a humeral head here instead of out here. In my career, I've never seen a posterior dislocation, not one. But if you did, then it would be out here and away from the ribs. It just kind of looked like it's floating out in no man's land. So all of this is what I talked about before. Over rotation and under rotation, what it's going to look like is this. All right, so you've got the axillary border here. I'm sorry, the axillary border is here. The vertebral border is here. So it's under rotated. The patient is either 2AP or 2PA. Notice the clavicle. The clavicle should be greatly foreshortened. So this is, not rotated hardly at all. And then with the over rotation, you've got the vertebral border as that fine line here, as opposed to the axillary borders, this puffy border here. We got rotation to lateral, so we've got over rotation.